Good afternoon. My name is Carlin Sagan. I am the Global Health Manager at the College of Medicine with the Division of Social Accountability. I'm not usually one that hosts these events, but we had an opportunity and jumped at it. So I do welcome you and bear with me as we go through this process. I am super excited to be here today, and I know there might be several people still joining us. I see more names popping up, but I think for the interest of time, we're going to get started now. I would like to start off by acknowledging the land on which we live, and that I live, work, and raise my family on Treaty 6 lands, the traditional territories of Nehiawak, Nakawe, Dakota, Lakota, Dene, and homeland of the Métis people. It has been front of my mind specifically this week in the wake of the National Day for Truth and Reconciliation that my privilege and the privilege of my family is bolstered at a cost to Indigenous peoples. I recognize my responsibility to genuinely participate in efforts to continue to build a better future for all of our children. And I genuinely hope that yesterday you all had the time to listen, reflect, and participate in what was offered by our community. And I will say that I'm also optimistic because I know that my children, 4 and 5-year-old girls, already have a better understanding than I did even a few years ago. So I do see progress, and that is very, very bolstering for me. So welcome to today, where we will be discussing defending our reproductive rights. We have with us 3 lovely individuals. We have Heather Hale, who is the Executive Director of Saskatoon Sexual Health. We have Lauren Tastad, who is a nurse practitioner with Saskatoon Sexual Health. And we have Dr. Rachel Gough, who is a family physician and longtime activist in this space. So for those of you who might not know, Saskatoon Sexual Health is a nonprofit organization located on Treaty 6 territory in the homeland of the Métis. They are a community resource that offers sexual and reproductive health education, advocacy, clinical and abortion services to Saskatoon and the surrounding area. Opening its doors back in 1971 as the Family Planning Association to provide birth control and promote responsible decisions around sexual health, and embodying several iterations, including as an affiliate of the Family Planning Federation of Canada. Almost 10 years later, in the fall of 2016, they went through another rebranding and became the Saskatoon Sexual Health. They provide sexual and reproductive health services in Saskatoon and area with an emphasis on safe, inclusive, empowering clinical care and education. They are bold activists for change, working with diverse communities to promote healthy and informed sexualities. So I'd like to set the stage for them to open up with a little bit of a discussion. They'll be doing a brief presentation and hopefully have time for discussion afterwards. If you need to message me personally for any issues, please do so, and I will be monitoring the chat as we go. So I'd like to open the floor and thank you all for being here today.
Thanks so much, Carlin. I'm just gonna share my screen here and get started. Seeing a number of folks in the call that are very familiar with this work and have been doing this work for a number of years. So excited to share this space with all of you. And of course, we tested this during our pre-run, but of course, you know, technology never works like it's supposed to when you need it to. So, all right, let's try this again. How's that looking? Joanna, am I doing okay there? Looking good? Okay.
It looks great, yep.
Perfect. All right. Well, thanks everyone for joining us today. As Carlin mentioned, my name's Heather Hale. I use she, her pronouns. While I'm originally from Treaty 4 territory in Southwest Saskatchewan, I'm based here in Treaty 6 in Saskatoon. So I wanted to give you a bit of an overview of what we were going to chat about today. I know that the title of this panel was Defending Our Reproductive Rights, but I've been a little bit feisty lately, and so I've said Reproductive Justice for the Revolution. So just to give you a brief overview of what we thought we might share this afternoon is that I talk a little bit about the historical and current context of reproductive justice in Saskatchewan today, but then also provide an opportunity for folks to hear from providers who are in clinic rooms and talking to individuals, and then hopefully leaving some time at the end for some questions and larger discussion. This is a community issue, and I think we're richer for having those perspectives from amongst the group. So I wanted to start by talking about reproductive justice, especially as we are the day after Orange Shirt Day, because reproductive justice is the framework that we use here at SSH for this work. And it is a framework for activism and thinking about the experience of reproduction. So what is reproductive justice? I'm sure folks are probably aware, but just so we're kind of all starting from a similar place. This is a definition and a concept that was really founded by Sister Song, the Women of Color Reproductive Health Collective. And the three main tenets of reproductive justice is that individuals have the right to determine when and if they have children and how they give birth, but also to determine when not to have children and how to prevent or terminate a pregnancy. And in that, it also expands to say that the right to parent children with social supports within communities that are safe and healthy. So it's fundamentally about the impacts of the social determinants of health and changing structural inequalities that exist in systems and that those have on individuals. So if folks are more interested, there is a great book. We read it at SSH for our book club that really goes into it. And I just wanted to pull one of the quotes from it that says, "The reproductive justice framework derives its vital depth from drawing attention to the persistence of this history, the ways in which the history of white supremacy operating in a capitalist system penetrates and misshapes the present." So really acknowledging that reproductive justice needs to be looked at with an intersectional lens and impacts different people differently. It also challenges us to shift the conversation from choice to access, which I think we've seen in the recent months, where some of the language around my body, my choice has been co-opted by anti-mask or anti-vax movements. And so really when we're talking about access, it's important because we understand that in Saskatchewan, we have the highest rates of adolescent pregnancies, unintended pregnancies, HIV, Hep Cs, and other STIs have been persistent and occurring for many, many years. So you've probably heard about some of the things that are going on in that space as well, and understanding that those have a link on our families and how people enter into reproductive spaces. So access to reproductive health is impacted by factors such as geography, poverty, education, inclusion, income, colonization. All of these impact on folks. And it's important that we think about access so that folks are able to choose their choices and to be able to support themselves financially, complete education if that's their intention, and really taking care of themselves and their families. It also has significant impacts on socioeconomic outcomes and employment. And I think we kind of know what happens when access is limited. We know that access is not equitable across Saskatchewan, and that often that leads to crisis situations and not being able to access the care that they need and having to travel to other communities. This is exacerbated with the cancellation of the STC bus line and overall impacts negatively on our communities. So I also just wanted to flag that reproductive health has a history of colonization and misogyny. And there's many examples that point to this. These are some of the ones that we reference just around, J. Marion Sims and his practice of gynecological experiments, also the syphilis studies and birth control trials, and really right here in Saskatchewan, and the forced sterilization that happened by the provincial government. So acknowledging that really, when we look at these issues, we need to take that broader lens. So a bit of some history here, and I think probably some folks in the room are well aware of this, that in 1969, that was the decriminalization of contraception and allowed for abortions under certain circumstances. And one of the advocates in this space was Dr. Henry Morgentaler. So he opened his first abortion clinic in Montreal in 1969. And certainly Roe versus Wade in the US happened in 1973. That has certainly been under attack in the States, and we're going to have a rally tomorrow in solidarity with folks in Texas and what's happening there. So we'll touch on that a little bit later on, maybe if we have an opportunity. But here back in Canada, the Charter of Rights and Freedoms came in and was enacted in 1982. And in 1988, the Supreme Court of Canada struck down the abortion laws as unconstitutional. So even though abortion has been legal since 1988, we know that access isn't always easy, it isn't always accessible. And just a few of those other things that dates to keep in mind in recent history, that Morgentaler's clinic was firebombed in 1992. 2 years after that, Dr. Bromalius, the first Canadian doctor, was shot for performing abortions. And there was similar incidents in 1995 and 1997. But really, since then, there continues to be some discussion. But when we look at what people say in Saskatchewan, overwhelmingly, 80% of individuals believe that abortion is a choice and a decision between an individual and their doctor. And some more recent things that have entered into the scene. One of the largest was in 2015, and the approval by Health Canada of mifepristone. It's a two-part drug for a medication abortion. So that was approved in 2015. But noting that also there was the lengthiest drug approval process on record, even though this drug has been on the market and been used widely in Europe and the States for many, many years. And despite it being approved, it wasn't covered in Saskatchewan at a tune of about $400 until 2019. However, in 2019, Saskatchewan became the last province to cover the cost of mifepristone. So I'm gonna maybe leave it there, and that kind of gives us a bit of a framework or a context to share some perspectives of providers. So I'm gonna turn it over to Dr. Gough. Dr. Gough, I'd invite you to share some of your perspectives as a provider, as an advocate, and as an individual who's passionate about this subject.
Thank you, Heather. I am very excited to be part of a FANL, all female identified panel. I feel like this is a big deal after watching like all male panels and the attention that got for a long while. And I was thinking back to a similar panel I had organized when I was a medical student, and we had Evelyn Reisner, who was then the executive director of Planned Parenthood and Saskatoon Sexual Health, a good friend and mentor of mine, Betsy Burry, who started the first Planned Parenthood in Saskatchewan. Again, one of my mentors and idols who passed away a couple of years ago. And then her husband, John Burry, who provided was one of the earliest abortion providers of the community clinic in Saskatoon, and BJ Fern, who I believe is still practicing medicine and has been a long time abortion provider, and also provider of methadone in Saskatchewan. So the two abortion providers, one past, one present at that time, were men, and here we are 2 female abortion providers and an all-female panel, so some progress. So my name is Rachel Gough. My pronouns are she, her, and I'm privileged to be here virtually with you and the wonderful humans at Saskatoon Sexual Health on Treaty 6 territory in the homeland of the Métis. I'm a white settler, and my sisters and I grew up between Saskatoon and Waka Lake. And I work as a family doctor in a primary care clinic in the old Waka Hospital, where my mom, who I think is here on the panel today, and her 7 siblings were born. I'm also Franciscoise by marriage. My partner and I are raising our kids in French. My mother-in-law grew up along the South Saskatchewan River near the National Historic Site of Batoche, which helps us not forget the Riel Rebellion and the violent, deliberate, genocidal history of colonialism on these lands. This summer, I read the republished book Half-Breed by Maria Campbell, whose home my patients passed by ambulance on their way from Waka to the closest emergency room in Rostern. Her story is just as powerful and relevant as when it was written in 1973, and is still one of the few by an Indigenous woman to be put to paper in a world where so many Indigenous people, especially women, are silenced, missing, incarcerated, and murdered. These incredible women that I've mentioned into my talk so far, and many others who are part of my story, inspire and ground me in the important work of reproductive justice. I still remember my first Medical Students for Choice conference when I learned that in countries where abortion is illegal, the only thing that changes is the number of pregnant people who die, not the number of abortions. And I'll never understand why abortion became such a controversial political and religious issue, when really it's just a necessary life-saving medical procedure and a basic human right. I had the privilege of providing surgical abortions in Saskatoon from 2014 to 2015 at the Women's Health Centre in collaboration with Saskatoon Sexual Health. I'm proud of the work we did to reduce barriers to timely access to unplanned pregnancy counseling, pregnancy dating, and abortions for those who chose it, especially for our northern patients who at that time had to make 2 trips down, some driving 5 to 6 hours each way for consultation, and then 1 to 3 weeks later, the abortion procedure. But there's still so much work to be done because in part, the goal of an abortion provider and an abortion clinic is to work ourselves out of a job. In all my experience working, volunteering, and training with Medical Students for Choice, the National Abortion Federation, and Planned Parenthood, I saw that the same providers and clinics that provide comprehensive sexual reproductive health care work equally hard to provide education, preventative care, and address the social determinants of health through advocacy and social justice work, which reduces the number of unplanned and unintended pregnancies. One of my dearest colleagues and mentors in BC closed her abortion clinic in 2019. After decades of hard work, she had trained so many providers to insert intrauterine devices, IUDs, for contraception and emergency contraception that the rate of unplanned pregnancies was down substantially in her area. Then, because of the advocacy work of her and many others, Health Canada finally went through the process to give Canadians access to the gold standard in early pregnancy abortion, mifepristone, also known as RU46 or mifegymiso, which is 97% effective with fewer side effects and complications and easier administration than previous medical abortion methods. The need for early pregnancy surgical abortions was so low, her clinic was no longer needed. Success. Like I said earlier, the goal of an abortion provider is to work ourselves out of a job. No one wants to have an abortion or provide an abortion if they don't have to. Just like no one wants to have a root canal or provide a root canal if they don't have to. But until there's free universal dental care and free comprehensive reproductive health care, in addition to universal basic income, where people can make decisions that are not based on money or basic survival, we'll continue to do far more root canals and far more abortions than necessary. Social determinants of health and the rising gap between rich and poor are the root of so much of the high and rising cost of medical care in Canada and around the world. Preventative dental care, access to healthy food, and fluorinated water cost a lot less than root canals. And education, access to comprehensive sexual and reproductive health care, including contraception and early first trimester abortions, cost a lot less than an in-hospital surgical abortion procedure. Poverty and income inequality are expensive, deadly, and the root cause of most illness. On a more personal note, I started as a volunteer at Planned Parenthood, now Saskatoon Sexual Health, in 2004, and applied to medical school that year. A few months after starting medical school, I started feeling exhausted, nauseous, and depressed, and found myself pregnant, unplanned and unwanted. I had all of the resources and supports I would wish for every person who finds themselves in this situation. All 121 million of us who have unintended pregnancies each year worldwide. I was able to confirm the gestational age of my pregnancy and access medications to help me pass the fetus and tissues less than 2 weeks after finding out I was pregnant at 6 weeks gestational age. I have no regrets. The day I passed the tissue, I felt relief and instantly felt better physically and emotionally. I got my life and my future back. I was able to finish medical school, get married to my partner who supported me through that experience, and we now have 2 beautiful, feisty children. The most common experience or feeling after an abortion is relief. The trauma comes from having to walk through a crowd of protesters leaving signs intended to scare, shame, and guilt people who are already nervous and isolated on their way in to access a necessary, life-saving medical procedure. The majority of my counseling with patients who came to me for abortions was undoing the harm from external pressures and negative attitudes about abortion. And I provided an equal number of abortions for people who said they were pro-life as pro-choice. Abortion's not a political or religious issue. The obstetrician gynecologist who gave me the medications to terminate my pregnancy and put in my first of 3 copper IUDs did her medical training in an era where abortions were illegal in Canada. She saw people who died from self-induced coat hanger abortions. Just like it's easy to take vaccinations for granted when we haven't lived through the era of polio, it's easy to take for granted access to abortions when we haven't lived through the era of large proportions of maternal mortality being the result of unsafe abortions. But this still happens all over the world. I had the privilege of spending a summer in rural Mozambique in 2007 as part of the Making the Links program. And at one point, half of the maternity ward was full of people with incomplete first trimester abortions, many of which were presumed to be because of illegal, unsafe, or self-induced abortions. So when I was invited back to Mozambique to assist in the first round of abortion training for primary care practitioners after abortion was legalized there in 2017, I couldn't say no. In the same town where I had lived 10 years previous, I sat through what they called a values clarification exercise, where people were asked to physically stand on one side of the room and then cross the line if they agreed with the following questions. Do you think abortion is wrong? About 10 of 24 of them crossed. They were asked for their reasons, and the couple said, because the baby's alive. Do you think abortion is a sin? 12 of them crossed. Do you think the life of the mother is worth more than the fetus? All of them crossed. Have you accompanied a woman suffering a complication from a clandestine abortion, as they call them? A patient, a friend, a family member? All crossed. And a few shared stories, women taking herbs and bleeding, others dying of infection, families torn apart. And finally, will you provide abortions? All crossed. We've forgotten. Our friends, family members, and patients aren't dying, so we forget. We get caught up in thinking that abortion is about religion or choice, but really it's about life, about the lives of people who die every day when abortion isn't legal, accessible, affordable, and safe. So back to where I started. 50% of people have, 15% of pregnancies are unintended, half end in abortion. The only thing that changes when abortion is illegal is the number of pregnant people who die. Abortion is a medical procedure, and access to contraception, abortion, and comprehensive sexual and reproductive health care are human rights that are closely tied to deep social inequality. Education for women and girls is the biggest predictor of the number of children a family will have, and the best thing we can do to prevent unplanned and unwanted pregnancies that lead to necessary life-saving abortions is to address the social determinants of health, poverty, and global inequality. Well, thanks again for inviting me here today, and I look forward to hearing from the others and to the discussion.
Thanks so much, Rachel, for sharing that impactful and powerful perspective. Thank you. That's a very clarifying position. Thank you for sharing that. I'd like to now turn the mic over to my colleague, Lauren Tastad. We here at SSH started providing medication abortions in June of last year. And Lauren was the driving force to ensuring and increasing that access here in our community. So Lauren, I'll maybe turn it over to you to talk a little bit about that process, some of the things that you've seen in your clinic, and some of your perspectives from the provision over the last little while.
Thanks, Heather. Can you hear me? It's all good. And thank you, Rachel, for your remarks. So yeah, as Heather said, I'm a nurse practitioner here at Saskatoon Sexual Health. I've been working at Saskatoon Sexual Health since 2016. I started out as an RN, and then I finished my nurse practitioner program in 2020. So came back in the pandemic and have been a medical abortion provider since the summer of 2020. So my experience has totally been in the pandemic. So that's been a little bit different. So yeah, I've been reflecting on that experience at our clinic over the last couple of years, and also in light of the pretty shocking developments in Texas. So I think we're all probably been following what's been going on there, and sort of, caused me to just think about that possibility and how things are different and maybe not so different in Canada. So probably we all feel kind of happy, grateful to be living in a place where we're not those, the basic right to have a legal, safe abortion is not currently under any kind of significant political attack. But I'm sure we're all also aware that having, the legal right to an abortion does not equate access to safe abortion in a timely, convenient, affordable way for everybody in our country and in our province. So I wanted to talk a little bit about barriers that exist to abortion, particularly here in Saskatchewan. So one of the biggest ones that we see is that geography is a really big barrier, as well as health system barriers. So as we may have touched on, probably everyone may or may not know this, that surgical abortion in Saskatoon can happen only up to 12 weeks. In Regina, up to 18 or 19 weeks gestational age, I believe. And those are the only two places for most people to get a surgical abortion in the province. So what that means for us, we provide medical abortion up to 10 weeks at our clinic. For people who are coming to us wanting a medical abortion, if they find out their dates are a little bit further along than they thought, they're not going to be within those 10 weeks and aren't eligible for a medical abortion, it's almost impossible for us at that point to get them connected to care to get a surgical abortion in Saskatoon. So to have like the consult appointment, get them booked into the OR, pretty much doesn't happen. So even for people who live in the biggest city in our province, who want a completely safe, completely legal abortion in the first trimester, they're having to travel hundreds of kilometers to have that procedure done. And then that problem is, can be just kind of exponentially compounded for people who are living in rural and remote communities where it's harder to get that basic initial consultation done, and then having to travel farther and farther to get the abortion care that they want and need. Just to mention a story that really sticks with me that I think is sadly not uncommon at all. Thinking of a woman that I knew who lived in a northern community in Saskatchewan, had 6 children. Youngest child was, I think, about 1, had some pretty serious medical conditions that required a lot of extra care. Found herself pregnant and wanted to end the pregnancy. Based on dates, was around 7 weeks of gestational age. When she came down to Saskatoon to see someone, the pregnancy was dated at 11 weeks and 6 days. So wasn't able to have a surgical abortion in Saskatoon. And for her to travel home to her home community, to her 6 kids, 5 hours up north, and then to make a round trip to Regina of, more than 16 hours travel round trip, it was just not feasible for her. So she ended up continuing this pregnancy that she really didn't want. So sadly, I think that's a situation that many people in northern and remote communities in Saskatchewan can find themselves in. So I think, this is not acceptable. This isn't something that we should accept in our community, and there's work to be done in our health system to improve access so that we don't just on paper have access to abortion, but that is a real option for people living in rural and remote parts of our province. Something else that I think about as another barrier to accessing abortion is the stigma that surrounds abortion. I think, a lot of this comes from the politicized debate that goes on, a lot of it in the United States, but also kind of vocal minorities who put up billboards and stand outside the hospital, expressing anti-abortion sentiments, public stances from religious groups, that kind of thing. There's that. And then I think a lot of the stigma can just come from silence. So we don't hear about it. People don't talk about it. And that just gives the impression that abortion is some sort of illicit or clandestine kind of thing, when in reality it's so common, so normal. But I think that just the stigma, the silence, the lack of information, the lack of voices saying, this is okay, you can ask for this, you can talk about this, makes it really hard for people to access the care that they want. Absolutely agree that, the less abortions that we are providing, the better. If people have access to the contraception that they want, the conditions that they need to prevent those unwanted pregnancies, but also would love to see a world in which people feel comfortable and okay talking to their healthcare provider about abortion. They know where to find that care if they need it. I think that, nobody wants to have an abortion, as Rachel said, if they can help it. But a lot of what makes abortion a difficult experience for people is not the actual experience, the physical experience of having it, so much as navigating, maybe doing this in secret because you're afraid to talk to your friends or family about it. If you don't want to talk to your family doctor about it because you feel like you're going to be judged by them, having to call around and find a different place to go, and potentially actually facing judgment and shame from the first healthcare provider that you might encounter. So to me, that's something that hopefully we can make some headway on breaking down that stigma, the abortion stigma. It's so amazing to hear people talk about their positive experiences of abortion. Thank you, Rachel. And there's been more people coming forward in the States, some female athletes who have come forward and talked about how important abortion has been in their life and how it allowed them to reclaim their futures. And I think that that is so powerful and so important to hear that, and just have voices out there saying, this was a great thing for me. other things that I think, maybe people in the healthcare system can do, having just basic education about abortion in medical and other healthcare curriculums, and not as, an ethical dilemma, but just as a basic part of primary health. If you're the person diagnosing a pregnancy, I'm sure, I'm not talking to people who know this, but not assuming that you know what the response is going to be, or what that they want to continue the pregnancy, or assuming that they don't want to continue the pregnancy, and maybe just kind of visual cues of this is a safe space to talk about abortion, posters, stickers, that kind of thing. So stigma for sure, I think, is a big one. And I was also going to talk a little bit about just my experience, which has been my only experience as an abortion provider, but talking about abortion during the pandemic. One thing that I saw at the beginning for sure that is I'm not seeing as much now was lots of people who their partner couldn't get a vasectomy because it was canceled because of COVID, or they couldn't talk to their doctor to get a birth control prescription, or they had a prescription for an IUD and then they couldn't get an appointment to have it inserted. So those were pretty common situations in the first few months of my life as an abortion provider. Haven't been seeing that as much anymore, thankfully. So that's great that people are actually able to access those basic conditions, primary healthcare services to prevent pregnancies. And a positive thing, I think, is that I think that the pandemic actually has improved access for some people in rural and remote communities in terms of accessing medical abortion. So with the SOGC coming out with guidelines on how to safely provide without, in circumstances where people qualify medically without necessarily doing some baseline labs and ultrasound, that was great for us and for me as a new provider, having that guidance to feel comfortable being able to provide remotely. And we've been able to provide medical abortion for many people in rural and remote parts of the province without them having to travel. So that's kind of a good thing that's come out of this. That's kind of everything that I had in mind that I wanted to say.
Great. Thanks so much for sharing those perspectives and those thoughts and those reflections, Lauren. I think, yeah, great to hear that. I know we work together, but it's, this is a topic of conversation at our lunch tables for sure. But it's also interesting to see once we've had an opportunity to reflect on some of the themes that have come up. Carlin, I know there was some questions that came in advance of the presentation. I'll maybe turn it over to you for those.
Yeah, I wanted to say thank you to all three of you for that. I feel like I learned a lot today, and just the genuine passion and importance that this actually plays is really evident. So I appreciate you guys taking the time to spend with us. I would like to open the floor for any questions that people may have, and by just writing them in the chat, I can kind of follow along as we go. I know there's going to be some, but we can start off with some of the questions that we got in advance to give people a chance to maybe think through their comments or questions that they might have. And one of which, again, talking about access, I think that was one of the themes that came across most evidently, was looking specifically in Northern Saskatchewan, and how can we improve healthcare access in Northern Saskatchewan around reproductive healthcare. And I guess with that, you were saying, Lauren, some of the new methodologies COVID has brought along. Maybe you could just elaborate on that, and we can discuss how to better improve that access.
I think you're muted, Lauren.
Am I good? We have provided for people in Northern Saskatchewan for sure. So if you have a positive home pregnancy test and are eligible, so no contraindications to the medication, we're not on hormonal birth control, have a pretty certain last menstrual period, I think that's pretty much everything. You can provide a medical abortion based on that. So you can do that either completely without going in for a lab or ultrasound report in some circumstances. Other times we have had people go into a local lab to do some baseline lab testing. And sometimes if an ultrasound is, reasonably easy to get, then we might want to do that as well. And of course, if it's not safe to proceed, would want to refer, or have them travel into a larger center. But that has been, I think really well received by people who are maybe prepared to travel, but are so happy to not have to take time off of work, find childcare, all of that stuff to get an abortion. So yeah, that's been great. So improved access to medical abortion, but still the issue, if people prefer a surgical abortion or need to have a surgical abortion based on medical conditions or their gestational age, then that's still a big barrier in terms of geography and where you can get that in the province.
I was going to add to that a little bit. So some of the work I was doing was, if people from the North would call into Saskatoon Sexual Health, they would get directed to me if they were wanting a surgical procedure, and then medical procedure, we were referring to the community clinic, a colleague there who was doing medical abortions. But I know just from like informal chats with friends and colleagues in the North, since if a gynae has been available, I have friends and family physicians in La Ronge and Isla Crosse who are providing medical abortions there as well. And I think like that is related to Mifegyne Meso, yay, we have access to that. And finally, all this sort of like, this is scary, we need to do all these million things, was like, actually not. These are pills we can mail to someone and they can order online and do themselves almost. And that's how it's being done in many, many parts of the world, especially misoprostol alone, but even the Mifegyne and misoprostol. But yeah, so now that those restrictions are limited, if a community doesn't have access to ultrasound, that was a barrier before, but now that's less of a barrier. And also, interestingly, like distributed medical education really helped with that too. So most of my friends who are providing abortions in the North or now working in the North and have made their lives in the North did like a residency program in Prince Albert, spent 6 months in La Ronge or 6 months in Isla Crosse, and then fell in love with the communities, fell in love there, partnered there, made their lives there, saw, the possibility of a life there, and then still work there, 10, 15 years later. So that's really exciting for me. And sort of that's a slow change that I've seen over time. There's always going to be a role for, Planned Parenthood, Saskatoon Sexual Health, and abortion clinics. But I think the more that it's just a like normalized part of general practice, obstetrics gynecology, I mean, that's where it belongs. And that's, like you said, that's where we see a lot of the people feeling like they can't tell their family doctor, or feeling judged, or coming across in drop-in clinics, people whose politics they're not sure about, even though it's not a political issue, or being misdirected intentionally, or because it's all a big secret. And, even primary health practitioners don't know where to send people. So.
Perhaps you could just address the comment in the chat as well, Rachel. Is that why does Saskatoon and Regina have different limits on progress time of pregnancy for surgical abortions? And do other places in Canada and US have different times or different limits? Sorry.
Yeah. Yes, and yes. It's provider preference. So, 1988, it struck down any kind of anything about abortion. So, there's lots of people who are like, oh my God, we could like be doing abortions like at 39 weeks. Like, no one does, no one would, that's not a thing, right? So, second trimester abortions are usually because people couldn't get in for a first trimester abortion, like didn't know they were pregnant, but most often just couldn't get their pregnancy dated, or, had a maternal serum screen while they were pregnant that showed a fetal defect or an anatomy defect that was incompatible with life, or where, an abortion was offered. And so that's what led to the delay. And yeah, but, most people would get a first trimester abortion. And so then providers choose. And so it's a different procedure under 12 weeks. 12 to 14 is very similar to under 12, but either you have that training or have got that training or you don't. And then the Women's Health Center, which is at City Hospital, where they do lots of sort of less invasive, it's under kind of local and light general anesthetic where you don't need to be intubated and don't need to have an anesthesiologist or whatever there. So any gynecological procedure that fits kind of under that realm is done at Saskatoon City Hospital at the Women's Health Center. And that was supposed to be modeled after the Women's Health Center in Regina, which was sort of started by amazing people, George Carson, Sally Mahood, like some real strong advocates and strong, pushers of like, this is just important, this should be done. And we can, work through the political and other barriers to make that happen. And then when it was modeled in Saskatchewan, there were some amazing people who were willing to do abortions who were already doing them, but there wasn't that same, I don't know, there was just a lot more fear and kind of protection, I think, around that too, and then sort of not being comfortable with the skills above 12. So yeah, it's just really variable from place to place, and it's usually some kind of like, this is how it was always done, some kind of like, historical stuff, some sort of safety and comfort level stuff, and then a lot of sort of provider comfort training preference too. That's complicated by stigma and this being seen as not a medical procedure, but a social, religious, political issue.
Thank you for that. I guess this is a question that probably is going to look a little bit differently depending on who's answering it, but how can we engage and advocate for doctors to offer better sexual health care so that community organizations are less strained by the circumstances they find themselves in? Is there a role, like, how do we engage with our physicians to make those services more available?
I don't know, Medical Students for Choice is a pretty amazing organization out of the States. And so there's a Canadian chapter. I was the Canadian coordinator. I can't remember what the title was. And then provincial one for a while as well. And we were sort of supported and encouraged to have chapters in various medical schools. So we started a chapter that we called RAG, which is a fun name, the Reproductive Action Group. I don't know if that's still running. And so that was, a good avenue for us to sort of have more education and advocate for more education around sexual health and abortion care. It's always odd though, right? Like, do we want this to be like an interest group on the side? Like, or should it just be everywhere, right? So, yeah, we get more training on vasectomies than we do on, no, we get more training. I think it's like there's 10 hours or something in medical school on erectile dysfunction and like 1 or 2 on abortion care. That was sort of the stats when I was in medical school. So it is incredibly biased. Like science is biased, research is biased, education is biased. And I think like that has to be changed, sort of structurally, and then continued. So I would say that like most of my colleagues and most of my, classmates and stuff, like they're doing decent contraception work. I don't think they necessarily they don't have as much time. I mean, we're paid for 10-minute visits and they don't necessarily ask the like preventative questions. They sort of respond to the question that people are coming with. They don't necessarily take the time to like put things up that sort of show that they're, open to talking about things. But yeah, there's just lots. But I think starting with education and making that a core part of curriculum that actually like reflects the frequency and the need, in what we're going to be doing later. Yeah, there's definitely room for that for sure.
Heather, Lauren?
Yeah, I'd maybe just echo some of the things that Rachel was saying. Like, I think, yes, absolutely, that training for medical training that includes information on reproductive health issues, but also medical policy that creates policies that require physicians to provide accurate, medically relevant, non-judgmental information on terminations and making timely referrals mandatory, I think would be great. And then if we kind of expand it out a little bit more, thinking about a public policy perspective, so creating those perspectives that address the social determinants of health that impact on access to reproductive health. And then if I get a wish list, I'll also throw in education and providing comprehensive sexuality education and reproductive health in the educational sphere, so that it's not just at school, but it's a kind of a lifelong journey, thinking about it throughout one's own experience.
Can I jump in there and say one thing? That's absolutely, you're right. Like, and it's always prevention and always education. But the like policy and practice stuff, I did a project on like what I think it was access to Plan B and PrEP, which wasn't really available, but at least STI screening and some prophylaxis for people who were raped through emergency departments. And at St. Paul's Hospital, we could not provide Plan B because it was a Catholic hospital. And then at the same time in Humboldt, which again, it was a Catholic hospital, they were doing vasectomies, but not tubal ligations because it was a Catholic hospital. So it's like Catholic hospital can't do anything related to sex. And also, we're only gonna do it for men and not for women. So, there is lots of really problematic policy practice that people haven't even looked at or realized are a thing that gets in the way, right? So some of that is just history that we've not bothered to undo, and then also policies and practices that need to change.
I would just add that I think they have just created a billing code for medical abortion. So that I don't really have a sense of how much that might change things, but potentially that will mean that more family doctors will take this on as part of their practice or something they would do for their patients.
Well, and I think for myself, one thing I learned today was that nurse practitioners can assist with a medication abortion, which is something I didn't know before today. So, having that knowledge out there. I wanted to see, Rhonda Gough has her hand up. So I'd like to invite her to make her comment or ask her.
Hi. Yeah, I just unmuted you, got you there. So Rachel mentioned me as her mom, and the topic of stigma has been raised a couple of times. And so I'm recalling with emotion in my voice, Rachel telling me that she was pregnant in 2004. And I recall that historically, the answer to I'm pregnant to anyone was congratulations. That was the answer. And so I recall not saying that. I recall trying to be the person that I thought I was and she needed me to be. And hopefully that is what her experience was. I at the time worked for an organization that had Catholic in its name, and had board members demand that staff march around City Hospital to complain about abortions that were going on. And my response was, if you want to do that as board members or members of the community, you go ahead. There's no way that I or any of us as staff members are. So there are places where we can try to stop the stigma from overtaking. And at the time, there was a childcare for teen parents that we had responsibility for. And my message again was, for those people who choose to have children, your job is to help those moms, those single moms and their babies live an okay life. That's your job, not marching around the hospital. So I guess it comes down for me right now is, what do we as citizens do? And Heather, I know you've mentioned some of the things and some of the wish list and so on, because it's so politicized, because there is so much challenge and stigma still today. What can I do as a citizen? What can other in my, age cohort who also have some interest and maybe some sway. Where do we put, I know that I could put my resources to your organization and have, but I'm looking to, we're talking about policy, we're talking about change. Who do we need? Is it our politicians who, maybe I have not elected as my MLA, but I'll leave you with that. Thanks.
Great question. Thank you, Rhonda, for that. And anytime, I'm gonna step on my soapbox here. You can't see it, but it's about to happen. So just be prepared. So I think that's a great question. So I think, there's always realms of impact about how we have these conversations around stigma or impact. So, having those conversations at the dinner table, at family gatherings. So having those conversations and challenging folks when they say something that might be a little like, that kind of twinges a little bit off. Like, and we can do that in a way that is non-confrontational. Tell me more about that. Where do you, how did you get that idea? Or tell me more about what you're thinking about that and explain, or here's another perspective you might want to consider. We would ask that you would join us tomorrow at our Solidarity March. So we're going to be meeting at the Vimy Memorial. So come out. Sometimes it's nice just to be in groups of like-minded people to renew our energy and our intent around these issues. The Women's March has organized an event, so Lights On event. So I'm sure someone will drop that in the chat. And then there's a couple other things I'll mention, and this is not an exhaustive list, but MLA Jennifer Bowes introduced a bubble law legislation. So an act to provide safe access to abortion services. So I would encourage everyone to download the letter that we kind of have templated out on our website. So you could write your MLA and tell them that this is important to you. And I would say, we're not the only organization who's working in this space. There's many great organizations. I know there's some folks here from Saskatoon, the Saskatoon Abortion Support Network. So they're always looking for support, whether that's through volunteers or fundraising for their trips that they make supporting folks to access services. And I think continuing just to like sharing those messages on Facebook and Instagram and all of those things are just ways. So those are a few. I'm sure folks have other ideas. This is a good group, and I'm sure lots of folks have other ideas too, but that's what comes off the top of my head as I hop off my box here.
We do have 2 minutes left. And there was a question from Jen back up in the chat a little bit further. And it was that, so clinicians are able to legally perform surgical abortions beyond 12 weeks in Saskatoon, but they require more training. Is that the accurate reflection?
Yeah, I think that's a okay way to put it. I think it's more training, and then you also need time. So you need OR time. So the time that providers get at the Women's Health Center at City Hospital is sort of like the time that, people get to replace hips and knees. So it's not that there's a lack of orthopedic surgeons, it's that there's a lack of OR time to do hips and knees. So it's kind of the same thing in the, obstetrics and gynecology ORs, or kind of mini ORs at Saskatoon Sexual Health. So many people have time there, not all of them do abortions, and then they choose based on their patients and the referrals they get, how much time is allocated to all of those procedures. So I was the first abortion provider who was not an obstetrician and gynecologist, who went through the process of, kind of created the process, I guess, for being able to do surgical abortions there. BJ Fern, Dr. Fern was doing them prior to me, and then stopped doing surgical abortions there kind of as I started. So I think that was sort of my gateway in, and now another colleague took over my time when I moved away in 2015. But so far there are no other family physician or non-obstetrician gynecologists doing surgical abortions there. So yes, legally you could do them at any stage, but you need a place to do them and the safe, sterile, environment for it. And it's more an issue of time and training and support there.
Well, just noting the time, I wanted to say thank you so much, Heather and Lauren and Rachel, for taking the time to meet with us today. If you scroll back a little bit through the comments, we did put in the links for our Solidarity Rally at Vimy Memorial, 2 p.m. tomorrow. Please do come out. And then again, there's also the Women's March event. If you're interested in partaking, it is lights on event. So you can do it out of the comfort of your own home. And as well, we have a survey. So please do take a minute or two to fill out the survey so we can get a little bit of feedback. And again, please just join me in thanking our panel today for the discussion and all the good work. So thank you so much, everybody.